Director for the Ocean Center. Today, I have the distinct pleasure of introducing our presenter, Dr. JoAnn Manson. But before doing so, I have a few practical matters to address. First, if you're requesting CMEs for this program, there'll be some information posted in the chat room throughout the talk, prompting you to send an email directly to Dan Litrinek, and he'll take care of your request. And also, as you listen to Dr. Manson's lecture and questions might emerge, please post them in the Q&A section of the Zoom feature. I'll be collating them and we'll present them to Dr. Manson at the end of her lecture. So moving on to our distinguished speaker today, I'm thrilled to be able to introduce my colleague, Dr. JoAnn Manson, who serves as the Chief of the Division of Preventive Medicine at Brigham and Women's Hospital, which is also the administrative home for our Osher Center. Dr. Manson is a professor of medicine and the Michael and Lee Bell Professor of Women's Health at Harvard Medical School. And she's also a professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. In brief, Dr. Manson's rich research portfolio focuses on women's health, randomized clinical trials in cardiovascular disease prevention, and population health and translational research. She has studied the role of lifestyle factors, diet, micronutrient supplementation, and reproductive and hormonal factors as predictors of chronic disease in women. Other major interests include the role of vitamin D, omega-3s, and folate in the prevention of cardiovascular disease, diabetes, and cancer. She has also studied extensively the role of exercise in the prevention of heart disease, stroke, diabetes, and breast cancer in women, and has been actively involved in studies of biomarkers and genetic predictors of cardiovascular disease and diabetes. She's one of the lead investigators on several landmark women's health studies, including the Women's Health Initiative, Nurses Health Study, the Women's Antioxidant and Folic Acid Cardiovascular Studies, among others. For this and her other work, she's been recognized with a remarkably long and impressive list of honors and awards, including the Women in Science Award from the American Medical Women's Association, the American Heart Association's Distinguished Scientist Award, the Harvard College Women's Professional Achievement Award, and among other institutions, she's been elected to the membership of organizations including the American Association for the Advancement of Science and also the Association of American Physicians. The title of Dr. Manson's talk today is How Vital Are Vitamin D and Omega-3 for Cardiometabolic Health? So without further delay, please join me in virtually welcoming Dr. Manson.
Thank you so much, Peter, for that very kind introduction. It's really great to be here, and I appreciate the opportunity to speak at the Osher Center Grand Rounds. I'm going to share my screen now. So I'll be discussing what we've learned from the vitamin D and omega-3 trial, VITAL, and at the end, I'll be acknowledging my co-authors and colleagues. So an overview of the talk is to review the rationale and the results of VITAL, which is a large-scale randomized trial of vitamin D and the marine omega-3 fatty acids in the primary prevention of both cardiovascular disease and cancer. I'll be describing recent updated meta-analyses of vitamin D, omega-3s, and these outcomes. And we found that the results of VITAL are actually in good alignment with the results of meta-analyses. I'll also briefly discuss a trial that we're doing now of vitamin D supplementation and COVID-19. I'll discuss which patients are more or less likely to benefit from supplementation with vitamin D or omega-3 fatty acids. I'd like to thank the supporters of the VITAL trial. First, VITAL is an investigator-initiated trial that is supported by the National Institutes of Health. The National Cancer Institute and NHLBI served as co-sponsors during the intervention phase, and NCCIH is currently supporting Vital during the extension renewal phase, and we're very grateful for that. We've had support from multiple institutes and agencies at NIH. I'd also like to thank Pharmavite for donating the vitamin D for the trial, Pronova Biopharma of Norway, and BASF for donating the omega-3, which is Omicor or Leveza fish oil, and for donating study pills, matching placebos, and calendar packaging for the trial. Finally, I'd like to thank Quest Diagnostics for measuring the serum 25-hydroxyvitamin D, omega-3 index, and other biomarkers at no cost. For those who want more details, we do have two concurrent publications on vitamin D and omega-3s and prevention of both cancer and cardiovascular disease in a New England Journal in early 2019. So this slide shows the overall design of the VITAL trial. So we have more than 25,000 US men and women. It's a nationwide trial. It's the largest randomized trial of vitamin D and also of the omega-3 fatty acids in the world. It's really the only true primary prevention usual risk population trial of the omega-3s. And it included men 50 years and older, women 55 years and older. It's a factorial design, meaning that we are able to study both the independent and the joint effects of the interventions. So for vitamin D, which is vitamin D3, 2,000 IUs a day, participants are randomized to vitamin D3 or placebo, and then further randomized to the marine omega-3s, EPA and DHA, a gram a day in a ratio of about 1.2 to 1. Our placebo was olive oil. That's become a hot topic now. What was the placebo for the omega-3 trial? It was not mineral oil. Okay, our median treatment period was 5.3 years. And we were very pleased to have racial ethnic diversity. And we had blood collection in more than 16,000 participants at baseline and follow-up bloods in about 6,000. And I'll explain why that's of interest. So the pre-specified primary and secondary aims of the trial were as follows. Primary aims to test whether vitamin D3 and or omega-3 fatty acids reduce the risk of a major CVD events composite of MI, stroke, and CVD death, and also a co-equal primary of reducing risk of total invasive cancer. The secondary aims were to test whether these agents lower risk of the individual endpoints within the CVD composite, MI, stroke, CVD death, or an expanded composite that also included coronary revascularization, PCI or CABG, and then to test whether the agents lowered risk of site-specific cancer, total cancer mortality, and to assess key subgroups, including by age, sex, race, ethnicity, and nutrient status at baseline. I will focus on cardiometabolic outcomes in this talk, but I'll mention briefly our findings for vitamin D and cancer. I'm going to begin with the omega-3 component of the trial because this is somewhat more straightforward and relevant to cardiometabolic health. So we know that the marine omega-3 fatty acids have effects on several biological pathways that are relevant to CVD. Much of this is through the eicosanoid pathway and anti-inflammatory pathways. We know at high doses that omega-3s lower triglyceride levels. There's maybe some effect on nitric oxide induced endothelial relaxation, perhaps some reduction in ventricular arrhythmias, but importantly, at least at high doses, the omega-3s have been implicated in increasing atrial arrhythmias, such as atrial fibrillation, decreased inflammation, perhaps decreased thrombosis, decreased blood pressure, some effects on reducing heart failure risk and reducing plaque progression, and increasing plaque stability. Now, some of these mechanisms are better established than others. Very strong evidence for the reduction in triglycerides and effects on cardiac arrhythmias and inflammation. Now, how did this hypothesis get started that omega-3s may be cardioprotective? Some of the evidence was from ecological studies, such as Greenland Inuits, Alaskan Eskimos, other groups. In fact, more recently, some of this evidence has actually been disputed. However, there was some evidence that these groups have lower risks of cardiovascular disease. Also, there were analytic cohort studies actually asking people about fish intake and following them forward, such as a meta-analysis of 13 cohort studies that suggested higher fish consumption was associated with a substantial reduction in fatal coronary heart disease. And also there were prospective cohort studies suggesting fish consumption, higher consumption was related to a lower risk of stroke. So it seemed that the omega-3s might be important for reduction of both CHD and stroke. However, shortly after we began the recruitment for the VITAL trial and began the trial, more evidence began to emerge that the randomized trials to date were really showing evidence for the coronary reduction and not so much for stroke reduction. There are far too many meta-analyses that have been done to show you would take the entire talk. There are actually at this point more meta-analyses of omega-3 trials than there are individual trials of the omega-3s. But in this meta-analysis from 2012, there was a significant reduction in cardiac death in the trials that had been done. And there was a suggestion of a reduction in other coronary events, but there was no signal for a reduction in stroke. And this will be relevant as I give you more information about VITAL and other trials. So what was our rationale for the dose chosen in the VITAL trial? We chose 1 gram a day of oral omega-3s, 84 milligrams of the combined EPA plus DHA in a ratio of 1.2 to 1. And we thought that this dose would be the best balance of efficacy and safety in primary prevention. In terms of how it relates to usual intake or other recommendations, for primary prevention, there have been general recommendations to have about 2 servings of fish per week. This would be close to 250, 500 milligrams a day, so it was quite a bit higher than that. In secondary prevention, those who have prevalent CVD, the AHA was already recommending about this amount, 1 gram a day. And the dose is about 5 times higher than average US intake. So it wasn't quite a bit higher than the current recommendations for primary prevention and higher than average US intake. And we thought in a primary prevention setting where people we're not like treating a disease, we're really expecting that if there are any risks, they would the benefits would outweigh the risk. We wanted to be sure that we weren't using too high a dose, that there would be side effects. This slide presents the overall distributions, clinical characteristics, and baseline characteristics of the VITAL trial. So the mean age was 67.1. We were very pleased that it was about 50-50 male-female. In fact, we had close to 51% women. There was racial ethnic diversity, as I mentioned, especially for vitamin D. We wanted to have at least 5,000 African-American or Black participants, and we did achieve that, 5,106. African-Americans are 20.2% of the cohort. We also had other races and ethnicities represented. And in terms of the prevalence of comorbidities, it was very close to what you would expect in a primary prevention volunteer population of midlife and older adults. Our follow-up rates and treatment compliance over an average of 5.3 years, which was the intervention phase. We had more than 93% follow-up for morbidity and more than 98% follow-up for mortality. So we were quite pleased with this. And our study pill adherence was also high. It was more than 83% over 5.3 years. And this was by self-report of number of pills being taken when we queried regularly about their adherence. But this self-report was supported by biomarker studies. We had high adherence according to these biomarker studies at baseline and at 1 year. Actually, we repeated this throughout the trial, and high compliance persisted through the entire trial. But the plasma omega-3 index was about 55% higher in the N3 group than at baseline, and there was less than a 2% change in the placebo group. The serum 25-hydroxy-D level was increased by 40% in the active treatment group and by less than 2% with placebo. This slide shows our overall results for the omega-3s and cardiovascular disease. And the top half of the slide shows our pre-specified primary and secondary endpoints. And the bottom half shows other pre-specified cardiovascular endpoints, but they were not primary or secondary. So for our primary composite of major CVD events, MI, stroke, CVD, death, we had a small but not statistically significant 8% reduction in risk, 0.92. Again, not significant. However, for total myocardial infarction, which was fatal and non-fatal MI, we did have a significant 28% reduction, and this was a nominal p-value of 0.003, which was also significant with Bonferroni correction. We had no reduction in stroke, and for CVD mortality and our expanded endpoint of major CVD plus coronary revascularization, we did not have a significant reduction. This is largely because of the inclusion of stroke and stroke mortality, stroke endpoints where we did not see a reduction. It was diluted out by the absence of a benefit for stroke. However, when we looked at other coronary endpoints, percutaneous coronary intervention was also significantly reduced at 0.78. CABG, we had smaller numbers, that was not significant. Fatal MI was 0.50, but numbers were small. CHD death was in the direction of benefit. And for a total CHD composite, which was MI, coronary revascularization, all forms, PCI plus CABG, as well as CHD death, we had a significant 0.83 or 17% reduction in coronary events. This slide shows the Kaplanmeier curves. You can see that for major CVD events, there appeared to be a slight separation of the curves after about 2.5 years. It was quite subtle. For MI, non-fatal and fatal MI, the curves began to separate a little after 1 year, 1.5 years, and they continued to diverge through 5+ years of follow-up. Again, this was a statistically significant finding for MI. Now, we were particularly interested in whether there were any subgroups that would have greater benefit than others. We were interested in nutrient status at baseline, and because fish consumption is the greatest contributor to omega-3s in the diet, we looked at average or median number of servings of fish per week, below the median, which was 1.5 servings per week, versus the median or above. And we did have an interesting finding here that the participants who started out below the median in terms of fish consumption did have a 19% significant reduction. This is in our primary composite endpoint of major CVD events, whereas those who were already above the median did not appear to benefit in terms of major CVD events. And this was a significant interaction p-value. We didn't see other significant interactions by age, sex, race, or other factors. Then in looking at myocardial infarction, where we saw overall that 28% reduction, we again looked by fish consumption and saw that in those who had lower fish consumption at baseline, so who had lower nutrient status, the omega-3s at baseline, there was a 40% lower risk of MI, but only a minimal, if any, reduction in those who started out with higher intake. This was also a significant interaction for the MI endpoint. Very interestingly, we saw that race was a strong effect modifier, 0.001, with African Americans having a substantial reduction in risk of MI with the omega-3, 0.23 hazard ratio. We are planning to explore this in much greater detail during the renewal phase. In terms of number of cardiovascular risk factors, we saw that the more risk factors the participants had, the greater the reduction in MI. So we saw really no reduction in risk in those who started out without vascular risk factors, 0.75 in those with one risk factor, and 0.57 among those with two or more risk factors. Given that most previous randomized trials of the omega-3s had pre-selected participants based on risk factor status, this actually suggested that with a larger trial of high-risk participants, even with 1 gram a day, there might be a substantial reduction. But we did not see interactions by age, sex, statin use, aspirin use, or baseline triglyceride level for the MI. Now, I just want to contrast our results with the Reduceit trial findings, which Reduceit was testing a different formulation, icosapent ethyl, which is a highly purified, stable form of the omega-3s. And it also was testing a much higher dose of 4 grams a day. And they did see a significant reduction in their primary endpoint, which included CVD death, MI, stroke, coronary revascularization, unstable angina. It was highly statistically significant. We're going to come back to why that may have been the case. Now, what about effects in vital on biomarkers compared to Reduceit? Well, we did see some a marginal reduction in triglycerides, about 6%, but compare that with 4 grams a day of icosapent ethyl, a 20% reduction in triglyceride level. There was a reduction in LDL cholesterol in Reduceit, but not in vital. And we saw a reduction in high sensitivity CRP in vital, but only in those with low fish consumption. That really seemed to be the group that benefited and not the others. Whereas in the Reduceit trial, there was an overall reduction in CRP. Moving on to meta-analyses, we actually published a meta-analysis 2 years ago in the Journal of the American Heart Association, and this included 13 trials and more than 127,000 participants. And the results were actually supportive of a statistically significant benefit for coronary events and for MI. This slide shows myocardial infarction, where overall, if you look at all the trials, the relative risk is 0.92. If you include Reduceit, the overall relative risk was 0.88. So even without Reduceit, there is a signal from the overall trials of omega-3s that there is a coronary or MI reduction. However, for stroke, and this is quite intriguing and really needs to be understood better, if you look at all of the trials excluding Reduceit, there really is not a single trial except for Reduceit, which is shown here, where there was more than a 25% reduction in stroke. All these other trials had neutral results for stroke. So either it requires a much higher dose, such as 4 grams a day, in order to see a benefit for stroke, or there may be something special about the formulation of icosapent ethyl. We did a dose response gradient analysis of the trials in our meta-analysis, and this did include Reduceit because there wasn't significant heterogeneity according to the dose response gradient. And we saw that for every 1 gram increase in dose, whether this was EPA alone or EPA plus DHA, most of the trials were EPA plus DHA, there was about a 9% reduction in total CVD. And so actually the VITAL trial results for total CVD were very much in line with this dose response gradient of seeing with about 1 gram that there would be 8–9% reduction in the major CVD endpoint. However, as you know, we haven't seen a meta-analysis that included the strength trial with a formulation that included a carboxylic acid formulation of the omega-3s at 4 grams tested in the strength trial. There actually was not a reduction in CVD. So an updated meta-analysis will be needed, and more research is needed to understand why that formulation seemed to be quite different. I'm going to now shift gears and move on to vitamin D. As you know, there are endogenous sources of vitamin D from sun exposure, UVB exposure. When we synthesize vitamin D in the skin, we also can get it from diet, especially fortified dairy products, some natural sources in fatty fish. So fish is a great source of both omega-3s and vitamin D, and from supplements. Vitamin D, also there are many mechanisms that have been postulated. Some of these are better established than others. Many of these are in vitro studies, cell culture studies, animal studies, but some evidence that vitamin D inhibits cell proliferation, induces apoptosis, cell differentiation, may inhibit angiogenesis, and a deep invasion of tumors into the tissue and metastasis. Also on the CVD side, some effect on regulating blood pressure, inhibiting vascular smooth muscle proliferation, and regulating glucose metabolism. However, I want to point out that almost every week you'll hear about a new study that a low vitamin D blood level, usually it's the 25-hydroxy-D that's measured, has been found to be associated with higher risk of heart disease or cancer or cognitive decline. And I want you to be aware that there are many potential confounders of the association between a low 25D and chronic disease outcomes. So that it may be that 25D is more of a marker than a true causal agent. And this is really, these observational studies are quite different from randomized trials of vitamin D supplementation. So you will have a low 25D blood level if you have poor nutrition, low dietary intake of vitamin D. You probably also have low fruits, vegetables, fish, you'll have low consumption of healthy foods. Also, there's some evidence that higher adiposity is associated with lower vitamin D blood levels because vitamin D is a fat-soluble vitamin. It is sequestered in the fat tissue, and almost all observational studies and randomized trials show that it's the 25D is lower in those with higher body mass index. And we know obesity is a risk factor for CVD cancer, type 2 diabetes. Also, people who have low physical activity levels may be spending less time outdoors. If you're not going to be, if you are inactive, you're probably not outdoors walking, playing racket sports, being out in the sun. And this can lead to low sun exposure. So it may be more of an incidental, association, or it's just related to people getting more sun exposure, also being more physically active. So a number of ways that vitamin D could be just a marker, but not causally related. And as we say in epidemiology, correlation doesn't prove causation. Now, what does the Institute of Medicine recommend in terms of vitamin D intakes? The last guidelines were provided in 2011. And at that time, the recommended dietary allowance was 600 IUs a day, not very much for ages 9 to 70, and 800 IUs a day for above age 70, both men and women. And many people aren't really familiar with what exactly the RDA means, but the RDA is the intake that covers the needs of at least 97.5% of the population. And this is in the absence of sun exposure. This is mostly for bone health because the IOM concluded that there wasn't conclusive evidence that vitamin D lowers the risk of cardiovascular disease or cancer, and really based these recommendations on what was needed for bone health. In terms of the tolerable upper intake level, which is defined as the level above which there is risk of adverse events, this was set at 4,000 IUs a day. So it's generally saying that as long as you're between 600, 800, and 4,000, you really don't have clear risks of adverse events. However, most of the research to date has been closer looking at levels closer to RDA levels long-term. So we don't really have good long-term evidence for the safety of 4,000 IUs a day. And according to the IOM, it doesn't seem to be really have any advantage over 600 to 800. But I think it's reasonable to be somewhere in the middle. 1,000, 2,000 should be quite reasonable, but just be aware that the IOM recommends that 600 to 800 IUs a day should meet bone health needs. So what we found in VITAL, I'm going to start with the cancer findings because these were actually of some interest and fairly intriguing. So for total invasive cancer, we had a hazard ratio of 0.96, but for cancer death, we saw 0.83, which didn't quite make statistical significance, and all-cause mortality was neutral. We did pre-specify that we wanted to assess latency and look at people who had been in the trial for at least 2 years, excluding the first 2 years of follow-up. And there we saw, 0.94 for invasive cancer, still not significant, but we did see a 25% reduction in cancer death and somewhat better results for all-cause mortality. The Kaplanmeier curves are shown here. Took a long time, which shows why latency analyses are important for total cancer incidence. The curves didn't separate until about 3.5 years, and it was slightly lower in the vitamin D arm. And for total cancer mortality, again, it was about 3.5 years, and then the curves began to separate. Now, there is evidence from other randomized trials that vitamin D appears to reduce cancer death. So we did a meta-analysis, again, in 2019. This included all of the trials that were large enough to look at cancer death. There was no reduction in cancer incidence, but all of these trials were on the side of showing a lower risk of cancer death, except for the New Zealand VITA trial, which was bolus dosing, monthly, less frequent dosing, which can have similar physiological effects. Overall, the hazard ratio in the meta-analysis was 0.87 for cancer death, and this was strongly significant with a P of 0.005. Now, again, with cancer, we were interested in looking at some subgroups that might benefit more than others. This is for the primary cancer outcome of total invasive cancer. We did see a signal that African Americans might do better, 0.77. We did not quite make a statistical significance. In terms of body mass index, however, which was pre-specified as a variable we wanted to look at as an effect modifier, we saw strong effect modification, 0.002, where those who were at a healthy weight had a significant reduction in the primary endpoint of total invasive cancer, but other groups did not. And I'm going to come back to this because there's now increasing evidence that there may be something about higher adiposity that counteracts vitamin D bioactivity. And many other trials we're seeing this for other endpoints, and many other trials are seeing this. We did not see a modifying effect of the baseline serum 2025 hydroxy D. Now in VITAL, we did have a mean level close to 30 nanograms per mil, but we had quite a few people, more than 2,000, about 2,000 who had a blood level less than 20 nanograms at the start. And that's considered insufficient. We did not see that they had a reduction in cancer with vitamin D supplementation. And we saw no modifying effect of age or sex. Also for cancer mortality, we saw BMI effect modification, where the BMI in the healthy range of less than 25. We saw a hazard ratio of 0.58, but really no reduction for the other BMI groups. And there was a significant interaction p-value. Now I want to show you that there are other trials that show modifying effect of adiposity. You may be familiar with the D2D trial. Dr. Pittas was the first author of that, and that was published in New England Journal, also in 2019. The overall results were a not significant reduction in type 2 diabetes with 4,000 IUs of vitamin D3. 0.88 was the overall hazard ratio. However, when they looked at those with a BMI below 30, they did a cut point at 30. They saw a 29% reduction that was significant in those who were not in the obese BMI category, and those with a BMI of 30 or higher did not have any signal for risk reduction. Since that time, there have been some meta-analyses of vitamin D and type 2 diabetes. We haven't yet published our findings in VITAL, but that will be very soon. But in meta-analyses that included, we did one that included 9 randomized trials, more than 43,000 participants. Again, this modifying effect of BMI was seen with BMI less than 30, a significant reduction in type 2 diabetes. Now, I was previously showing you, for cancer, there's this modifying effect. And now it seems to be quite distinct for type 2 diabetes as well. And a second meta-analysis was done with very similar results, a significant reduction in type 2 diabetes in those with BMI below 30, but not those above 30. So this is really something that needs to be explored further, because it may provide clues to how to make vitamin D supplementation a benefit for people of all BMIs. But at the present time, it seems to be less effective among those who have high BMIs. Now I'm going to move on to cardiovascular disease, where we saw no effect of vitamin D supplementation. And as I'll show you, this is also consistent with the meta-analyses. So for the primary endpoint of major CVD events, it was 0.97, really no reduction for any of the other CVD endpoints, and also no modifying effect of age, sex, or BMI here, or baseline 25 hydroxy D. It was just extremely null. Now, in a meta-analysis, it's a little hard to see, but it's the pooled hazard ratio looking at 21 trials with more than 83 participants. Well, I mean, you don't get much more null than this. 1.00 with a confidence interval 0.93 to 1.08. Really nothing going on for vitamin D supplementation and cardiovascular disease. Now, why would it be that vitamin D might actually have a benefit for cancer mortality with higher intakes, but no reduction in CVD? Well, we don't really know the answer to this question, but the observational studies also show a very intriguing pattern that, like an endpoint such as colorectal cancer, this has also been seen with some other cancers, that these are observational studies, just looking at baseline 25D in relation to like future risk of colorectal cancer. as you get to higher blood levels, even above 40, and our achieved blood level was close to 41 nanograms per mil, about 104 nanomoles per liter, with a 2.5 to 1 ratio of nanomoles to nanograms per mil. But the point is, in VITAL, we got to be about here, which is close to the nadir of the curve for colorectal cancer. And you can see that there's a gradual reduction until you get to about 40, 45, then a bit of an uptick in the observational studies. Whereas in the observational studies of cardiovascular disease, you reach the nadir of risk as you get to about 20 nanograms per mil, and then it just plateaus. There is no further decline as you get to 40 or higher. So I think the point is that with cardiovascular disease, the needs are much more limited. Similar to bone health, you just really don't need to be above 20 nanograms per mil, which is what's recommended for bone health. And this may be because teleologically, CVD health was just so critical to survival that it required really very little vitamin D. But there may be different pressures in terms of cancer prevention, which was not very common during our evolution. So VITAL, in terms of side effects and adverse events, the good news is we saw no significant side effects with either agent at these doses. We saw no increased risk of hypercalcemia with vitamin D at the dose of 2,000 IUs a day of D3. We saw no increased risk of bleeding with 1 gram a day of the omega-3s, and we saw no increase in GI symptoms with either agent. And so we were able to demonstrate relative safety of both supplements over an average of 5.3 years. We have several other ancillary studies that have either been reported or will be reported soon. I don't have time to go through all of them. We'll be reporting cognitive function and diabetes and hypertension very soon. We've reported that heart failure, omega-3s may be of some benefit for recurrent heart failure. We'll soon be reporting autoimmune disorders. Atrial fibrillation was neutral at these doses, but has been elevated with very high doses of omega-3s, as I mentioned. And we're going to be reporting details of bone health. And mood disorders were, for vitamin D, we've reported they were neutral. And some of these other endpoints we'll be reporting soon. So in conclusion, in the VITAL trial, neither the omega-3s at 1 gram a day nor vitamin D at 2,000 IUs a day significantly reduced the primary endpoints of major CVD events or total invasive cancer. With the omega-3s, as I mentioned, total MI, non-fatal plus fatal, was reduced by 28%, which was statistically significant. The greatest reduction was in those with low fish consumption and in African Americans. Both of these need to be explored further, both of these findings. Percutaneous coronary intervention, fatal MI, and total composite CHD were also reduced by omega-3s in VITAL, but we saw no reduction in stroke. Vitamin D showed a reduction in total cancer mortality in analyses accounting for latency, but reductions in total invasive cancer only among those who had healthy weights at baseline. The Reduceit trial, as I mentioned, icosapent ethyl 4 grams a day, did show significant reductions. Importantly, showed reductions in stroke as well. And our updated, and ours and others who have done updated meta-analyses show CHD and CVD reduction with the omega-3s, a signal for a dose response gradient, and some evidence that EPA may reduce risk more than DHA, and higher doses, especially higher doses of EPA may be of particular benefit. What can we say in terms of clinical and public health implications? Well, in primary prevention, well, for the omega-3 fatty acids, I think it's still going to come down to encouraging fish consumption of this should be greater than or equal to 2 servings per day, because even if the omega-3s aren't a benefit, the fish will replace less healthful foods such as red meat or highly processed foods. If people have low fish consumption, it is reasonable to discuss with your clinician an omega-3 supplement. We tested a prescription omega-3, Leveza or Omicor. If you're going to take it over the counter, do look for labeling that suggests it undergoes, an audit for stability and purity. But depending on other risk factors, if for example, people have risk factors for CHD and they're not having any fish, they may want to discuss with their clinician whether they should take a supplement. If they're vegetarian or vegan, they can't take a fish oil supplement, but algae-based supplements could be an alternative. I think we need a replication trial in high-risk primary prevention, especially studying those who studying African-American Blacks, and also studying those who are at higher risk in primary prevention. Vitamin D, no clear change from the Institute of Medicine, National Academy of Medicine 2011 guidelines. We have no clear indication for CVD prevention. I think we still need more research on cancer. However, I do think it's reasonable to take, as long as it's less than about 4,000 IUs a day, which is tolerable upper intake. I think it's reasonable to take 1,000, 2,000 IUs a day of vitamin D, especially during this pandemic. And individualized clinical decision-making is needed for people who have health conditions such as bone health problems, osteoporosis, history of fracture, malabsorption disorders, and other conditions. Many people will need much more than what the IOM recommends. Avoid mega dosing. Certainly avoid more than 10,000 IUs a day, which has not been well studied longer term. And stay tuned for vital extended follow-up ancillary study results in the next several months. And we hope to have additional research on high dose EPA, especially in African Americans. I want to mention that we're doing this vitamin D for COVID trial. This is a pragmatic cluster randomized trial. We're testing a dose. It starts out with 10,000 IUs a day for 2 days, a loading dose, then 3,200 IUs a day for 1 month to see if it can reduce the severity of COVID illness, reduce severe symptoms, and reduce healthcare visits and hospitalizations. I'd like to thank and acknowledge all of the participants in VITAL around the world, the more than 25,000 participants who made this trial possible, and all of the investigators and staff, and a special thanks to just a few people here, to Nancy Cook, to Ayman Lee, Sammy Amora, Christine Albert, Ed Giovannucci, Walter Willett, and Julie Buring. And also, I would like to acknowledge our prior project manager, David Gordon, and Tricia Copeland, and Denise D'Agostino for their contributions to the trial. So thank you so much for your attention, and I would be happy to take questions at this point.
Well, thank you, Dr. Manson, for a remarkably comprehensive and really rigorous presentation. I have some questions that are coming in from different people in our audience. One sort of speaks to the audience here in terms of integrative medicine. Sometimes it's, do I take medicine or pharmacological medicine, or do I take supplements and diet? And often, we believe that it's not an either or. But I noticed in the Omega-3 trial that you included people who were taking cholesterol lowering meds as well as antihypertensives. And I'm wondering whether those factors impacted the benefits of both supplements, and whether you looked at those modifying effects.
So we did look at statins. We've done several analyses looking at effect modification by statin use. and it was not a substantial effect modifier. We've looked at aspirin, and it was not an effect modifier. We've looked at our results within those who had hypertension versus no hypertension. And we haven't really seen that antihypertensives were an effect modifier, but we did see a greater benefit of the omega-3s in those who had hypertension or any cardiovascular risk factor.
So this really speaks to it's not an either or, that both of these can work
Absolutely.
additively or synergistically.
Absolutely.
There were some specific questions around the omega-3 methods. And one was in relation to your observation about the effects of eating fish. And the question was, did you specify which kinds of fish people were consuming, and whether that might have had an effect on your observations?
Yes, so the analyses that I showed you were of total fish consumption. We did ask questions about the type of fish, separating out the dark fatty fish and the shellfish and all of that. And we do plan much more detailed analyses. But at the present time, because for statistical power reasons, we were just focusing on total fish consumption in those analyses. But even looking just at total fish, number of servings per week, less than the median versus median or higher, we saw a significant modifying effect. And I think that this is really important, suggesting that at least with a dose of 1 gram a day of the omega-3s of the Leveza or Omicor, if you are already getting like 1.5 or 2 servings of fish per week, there doesn't appear to be much incremental gain or benefit from taking this omega-3 supplement. But if you have very low fish consumption, and this is really very much in line with expectations, that if you have low status of a nutrient, you might benefit more from supplementation. And some people really do not eat fish. They don't like fish. It's really surprising to me, but some people don't. And people have fish allergies, so they can't eat fish. And so I do think that in people who have very low fish consumption, a supplement may be of value and should be discussed with the clinician. And in terms of whether over the counter or whether to do it as a prescription pill, it is really important to understand that virtually every randomized trial of the omega-3s that I showed you in the meta-analyses and that I've been talking about has been of a prescription omega-3 product where there's very strict quality control. The over-the-counter supplements, some of them are actually very good and have had good results in terms of stability, quality, consistency of dose, but others are not. There's a wide range, and it's important, as I mentioned, to look at the label, look for US pharmacopoeia, look for some evidence that there's been some quality control, a seal for some quality control testing at a minimum. But if you're in a really high risk group and you have low intake of omega-3s, low intake of fish, you may want to talk with your clinician about actually getting a prescription product.
So an obvious question that's intriguing and profound results that you have are that there are differences in the subgroup of African-American participants. And presumably you've controlled for socioeconomic factors as well. So do you have any initial hypotheses of what may make, if this result does stand up to be robust, what may underlie that subgroup difference?
So the first thing we looked at was whether fish consumption differed among African Americans and non-Hispanic whites or Hispanic whites. And what we found was that there actually was not lower fish consumption, slightly higher fish consumption. So it's not related to baseline fish consumption being low in this group. There is some evidence that some gene variants related to fatty acid synthetase, that there may be some differences in these genes, and we want to really delve deeply into fatty acid profiles and gene variants that may be predictive of getting greater benefit from omega-3 supplementation. and whether these predictive variables differ by race, ethnicity. So that's a very strong interest that we have during the renewal phase.
I'm going to shift to a couple quick questions on vitamin D. So I have a personal interest in vitamin D and falls and fractures because of my interest in exercise. And there was a new study that you've probably seen that came out just this year by Apple, which was a large-scale vitamin D dosing study up to 4,000 units, and they found a null effect. And I'm curious if you want to comment on that in terms of prior studies suggesting that it might be helpful for fall prevention and fractures. I think they focus mostly on falls and not fractures. And then the corollary question, or the additive question to that is, again, in integrative medicine, are you aware of studies that have looked at the combined effects of exercise and vitamin D? And it would seem that putting those together is a very pragmatic question, and there may be synergies of people who are doing exercise that need muscle and bone support along with that supplementation.
Yes, so this question about vitamin D supplementation in falls is extremely controversial. The STURDY trial, the trial by Larry Apple at Hopkins, did suggest that there was no benefit of supplementation. And in fact, the higher the dose in their initial dose ranging studies, the worse the outcomes in terms of falls. There's also fairly strong evidence that very, very high dose supplementation, especially bolus dosing that's given infrequently, such as in the Sanders trial that was done in Australia, can actually increase the risk of falls and fractures. So there's something very unphysiological about high dose bolus dosing given infrequently. It may actually downregulate the vitamin D receptor or have some effect such as that. However, we also know that getting adequate vitamin D, not being deficient in vitamin D, is really important for bone health, especially when combined with adequate calcium intake, and also important for musculoskeletal health. So I think we have a situation here where the amount of vitamin D that is needed, required for fall prevention is actually, or even for bone health, increasingly the evidence is suggesting this, is really fairly modest. And higher, more is not necessarily better. And in fact, it can be worse, especially when more supplementation is given in an unphysiological way. We did publish our results from VITAL on falls. We very recently published them in the Journal of Clinical Endo and Metabolism, and the results were null. So most of the trials that are studying populations that already have pretty adequate intake, they are already at a 25 hydroxy D blood level that's above 20 nanograms. There just really is not evidence of benefit for supplementation. However, in populations such as institutionalized and nursing homes, much older populations where vitamin D deficiency is quite prevalent, there does seem to be evidence for benefit of calcium plus vitamin D supplementation for preventing fractures and falls. Your question about exercise together with vitamin D, it's actually a really important question. We've had a strong interest in this. This is what is being looked at in the Do Health European trial, which is, we call it the Bridge to Vital, because it has a very similar design in terms of its testing, similar doses of vitamin D and omega-3s, but it's a much older study population, and it has an exercise component to it, so that there's an opportunity to look at whether exercise interacts with vitamin D supplementation or omega-3 supplementation. And the fall results and bone health results have not yet been published in detail, but there is a lot of interest in this question of whether there's an interaction with exercise, and that trial, the Do Health trial, will be able to answer that question. We're expecting results to be out within 6 months or so.
Well, thank you. Well, I want to say thank you so much for such a thoughtful and rich and rigorous presentation. We'd love to have you back over and over again. Your knowledge of all kinds of supplements and that very balanced evidence-based approach is just really critical and in line with what we hope to share through the OSHA Grand Rounds. I want to just, so thank you so much. And I'm sure if we were in a big audience, you would hear everyone clapping vigorously. But
Thank
I
you.
want a couple of comments as we finish up. I want to thank all the attendees for showing up today. I also hope that you'll join us for promises to be another great lecture to be presented by Dr. Jun Mao from Sloan Kettering Hospital, New York, on his topic is integrative ecology, evidence-based medicine meets patient-centered care, and he's one of the leaders in the field of integrative oncology. I want to note that that event will take place on the second Tuesday of September. This is unusual, but due to the proximity of Labor Day, it's going to happen on September 14th. Also, I just want to announce that there's some workshops being offered through the Osher Clinic. One of them is the Tai Chi workshop being offered this Saturday, and it's of note free to all MGB employees and their family members through a very generous grant that we received from the MGB System Behavioral and Mental Health Program. And finally, please go to our website. You can see archives of all the previous Grand Rounds, including a recording of this one. You can also see our new strategic plan and be on the lookout for the RFA for our 2022 OSHA Pilot Grant Program. We'll be sending out requests for letters of intent and applications in September. So enjoy the rest of your summer and hope to see you in early September. And thanks again to Dr. Manson.
Thank you. Have a great rest of the summer.